Ischemic heart disease, that means a condition involving the heart as a result of myocardial ischemia. Ischemia means deprivation of oxygen. So, ischemic heart disease has got three components: ischemia, heart, and disease. Ischemic heart disease, in short, a clinical disorder of the myocardium as a result of inadequate blood flow with oxygen and other essential nutrients to a portion of the myocardium. This is the ischemic heart disease. The most common cause of ischemic heart disease is atherosclerotic plaque, narrowing the lumen of an epicardial coronary artery or arteries, adequate enough to produce a segmental or regional reduction in blood flow to the myocardium, producing hypoperfusion or reduced perfusion of the myocardium, rendering it vulnerable to ischemic injury. Now, to understanding the pathophysiology or central to the pathophysiology of myocardial ischemia is basically an understanding of the interaction between supply and demand. That means myocardial oxygen supply and myocardial oxygen demand. Now, the factors responsible for myocardial oxygen supply and the factors responsible for the myocardial oxygen demand. Coming to the point of myocardial oxygen demand, that is dependent on number one, heart rate, number two, cardiac contractility, number three, myocardial wall tension or stress. So again, I repeat: heart rate, myocardial contractility, myocardial wall stress or tension. And the supply is dependent on number one, an adequate oxygen carrying capacity of blood, number two, an adequate amount of coronary arterial blood flow. Coming to the first point, that means the oxygen carrying capacity of blood, that is again dependent on an adequate level of inspired oxygen in the blood. Second, functional status of the lungs. Third, presence of hemoglobin and hemoglobin function. That means hemoglobin concentration and function. An adequate blood flow is dependent on the series of arteries, arterioles or capillaries to the myocardium. Myocardial ischemia occurs when there is an imbalance between the supply of oxygen and other essential myocardial nutrients, and the myocardial ischemia. Central to an understanding of the pathophysiology of myocardial ischemia is the concept of myocardial oxygen supply and demand. And determinants of myocardial oxygen demand, that is MVO2, is heart rate, myocardial contractility, and myocardial wall tension. Then comes an adequate supply of oxygen to the myocardium that requires a satisfactory level of inspired oxygen in the blood, and oxygen carrying capacity of the blood, that is determined by the inspired level of oxygen, pulmonary functional status, and hemoglobin concentration and function, and an adequate coronary blood flow. Now coming to the point of the coronary blood flow. Coronary blood flow occurs in a phasic or cyclic fashion, mostly or majority done in the diastolic period. And the majority of the vascular resistance to coronary blood flow is dependent on a three set of arteries and arterioles such as large epicardial coronary arteries, resistance 1, pre-arteriolar small arteries, resistance 2, that is R2, and lastly arteriolar and intramyocardial capillaries and arterioles, that is the R3. Maximum resistance is at the level of R2 and R3. R1 resistance is minimum in this setting. Now, on the basis of segment and size, main stimulus for vasomotion, main function, and the percentage of resistance to the coronary blood flow. We have got two subsets of the circulation. One is macrocirculation, another is microcirculation. Macrocirculation is constituted by epicardial coronary arteries with a diameter exceeding 400 micrometer. Then comes the small arteries, that is the diameter less than 400 micrometer. Then the third segment is arterioles, diameter less than 100 micrometer. Then the capillaries, diameter less than 10 micrometer. So segment and size, macrocirculation is constituted by epicardial arteries and the small arteries. Microcirculation is constituted by the arterioles and capillaries. More than 400, less than 400, more than 100, and less than 10, both in the units of micrometer. Now, main stimulus for vasomotion. For the epicardial coronary arteries, it is flow. For the small arteries, it is the pressure. And for the arterioles, it is the metabolites and main function. Macrocirculation, especially the epicardial coronary arteries and small arteries, are responsible for the transport of blood to the myocardium, whereas the arterioles and a small portion of the small arteries is responsible for regulation of coronary blood flow. Regulation may be auto-regulation and metabolic regulation. In response to physiologic stress, the regulation is known as metabolic autoregulation, such as in a setting of exercise, exertion, or emotional stress. The coronary blood flow regulation is known as metabolic regulation. On the other hand, in response to changes in the pressure, regulation is known as auto-regulation. Now, percentage of the total resistance to blood flow. The picture or diagram showing a minimum level of resistance is at the level of epicardial coronary arteries, that is the R1. Maximum resistance is in between R2 and R3. So blood flow is also dependent on the degree of resistance in the vascular bed. Again, I repeat, on the basis of segment and size, second, main stimulus for vasomotion, third main function, and fourth percentage of resistance offered by the vascular bed. We can categorize macrocirculation and microcirculation. Macrocirculation means epicardial large arteries and small and arteries, and microcirculation means arterioles as well as capillaries. Capillaries are responsible for the exchange of the nutrients and gases. Now, factors regulation coronary oxygen balance. This is a diagrammatic representation what I have told previously. First, extravascular compressive forces, autoregulation, metabolic control, humoral factors, neural factors, diastolic phase, vascular resistance, coronary blood flow, supply, and balanced by oxygen carrying capacity, systolic wall tension. This is the demand related to the heart rate, and this is the contractility. The show integrated approach between the supply and demand. That is the interaction between supply and demand is the crucial or central point in the pathogenesis of coronary artery disease or ischemic heart disease. Now, causes. Coronary blood flow to a region or segment of the myocardium may be the result of number one, atheroma, number two, thrombus, number three, spasm, number four, coronary ostial stenosis, number five, coronary arteritis, example, systemic lupus erythematosus, all are responsible for the mechanical obstruction. So mechanical obstruction is due to atheroma, thrombosis, embolus, coronary ostial stenosis, coronary arteritis, and second, decrease in the flow of oxygenated blood. Number one, reduction in hemoglobin concentration and function, that is anemia. Number two, presence of abnormal hemoglobin, that is the carboxyhemoglobin. High demand for oxygen may occur and increase in cardiac output, as for example, thyrotoxicosis or myocardial hypertrophy, especially LVH, in a setting of aortic stenosis or hypertensive heart disease. Myocardial ischemia most commonly arises as a result of obstructive coronary arterial disease or CAT in the form of coronary atherosclerosis. Now, risk factors for the heart disease or ischemic heart disease. Multi-dimensional view of the cardiovascular risk category, clinical or metabolic. Second category, body composition. Third, behavioral. Fourth, external or social. Risk factor. Now, clinical or metabolic, hypertension 33.5%, diabetes mellitus 21.5%, hyperlipidemia 15%, body composition, overweight 6%, obesity 34%, behavioral smoking 20.7%, smoking 20.7%, and external is the air pollution, psychosocial factors. Influences outer the circle. This is the inner circle, this is the outer circle. Hyperuricemia, vitamin D deficiency, gut microbial health, physical inactivity, diet style, sleep disorder, and external, that is the air pollution or psychosocial disorders. In summary, psychosocial factors, vitamin D deficiency, physical inactivity, hyperuricemia, sleep disorders, gut microbial flora, air pollution, diet style, diabetes mellitus, overweight, smoking, hyperlipidemia, and hypertension, as well as the obesity. Pathophysiology. The coronary atherosclerosis is the central point in the pathogenesis of atherosclerotic occlusive epicardial disease. Central to the point or crucial to the point of coronary atherosclerosis or atherosclerosis in general is endothelial dysfunction. Endothelium is responsible for the maintaining vascular integrity and homeostasis. Now, atheroma produces as a result of endothelial dysfunction or injury leading to increased permeability to the oxidized lipids and inhibition of an inflammatory process leading to the genesis of atherosclerosis through various stages. Number one, the initial lesion, that is the stage 1 endothelial dysfunction and the formation of the foam cells. That means lipid-laden macrophage. Stage 2, fatty streak or fatty streak formation. That means incorporation of the intracellular and a very small amount of extracellular lipids. Third, this is the intermediate or transitional lesion, that is the stage 3. That means enhancement of the accumulation of extracellular lipids. Third, the atheroma formation, a well-defined lipid core, mainly extracellular lipids. Lastly, advanced or fibrolepid atherosclerosis or plaque, having a cap that is composed of collagen and fibrous tissue. And lastly, the complicated atherosclerosis. Complicated means encroachment of the lumen of the arteries or instability in the form of subject to erosion, fissuring, rupture, or ulceration. And this is the stage. Type 1 lesion, isolated macrophage and foam cells. Type 2, fatty streak lesion, mainly intracellular lipid accumulation. Type 3, intermediate lesion, that means small extracellular lipid. Type 4, atheroma, that is the core of extracellular lipid. Type 5, fibroatheromas or fibrolipid plaque. And lastly, the complicated lesion, that means either encroachment of the lumen or subject to ulceration, fissuring, or rupture. Sure. The coronary atherosclerosis, in short, a complex process of inflammation as a result of endothelial dysfunction or injury, producing fibrolipid deposition within the intima that may encroach the lumen or that may undergo thrombus formation, producing reduction in blood flow. Now, mechanisms of thrombosis in the setting of coronary atherosclerosis. সাধারণত দুটো প্রসেস ঘটে ফার্স্ট ওয়ান ইজ সুপারফিশিয়াল and second one is deep. Superficial or first process means denudation of the atherosclerotic plaque with exposure of the sub-endothelial connective tissue and collagen fibers. While the second process involves deep fissuring, ulceration, rupture, exposing the sub-endothelial tissues that may invite to process one platelet aggregation and activation, second activation of the coagulation cascade, leading to genesis of thrombus. One thrombus is responsible for encroachment, another is responsible for encroachment, rupture, and thrombus formation with resultant complete occlusion. And depending on the degree of occlusion and the process of coagulation cascade and thrombus genesis, ischemic heart disease or clinical manifestations are responsible, like stable angina pectoris, unstable angina pectoris, non-ST segment elevation myocardial infarction, and ST segment elevation myocardial infarction. First process superficial endothelial injury or endothelial denudation, endothelium. Second process, that is the deep endothelial injury, plaque fissuring. This is the thrombus formation enclosing the lumen, and with the rupture of the cap of the plaque. Here is not the rupture of the cap. This is now clinical consequences. Depending on the degree of atherosclerosis and degree of luminal stenosis or narrowing, the pathophysiological the pathophysiological consequences are the horizontal bar, progressive manifestation of ischemia, and the vertical bar, the process of the atherosclerotic involvement or magnitude. First of all, endothelial and microvascular dysfunction, then decreased subendocardial perfusion, ultimately regional wall motion, and the systolic dysfunction. এত ডিটেলস দরকার নেই। So progressive manifestation of ischemia and progression of the atherosclerosis result endothelial and microvascular dysfunction, decreased subendocardial perfusion, altered metabolism, and abnormal ST segment at this stage, microinfarction or myocardial fibrosis, diastolic dysfunction, segmental hypoperfusion, regional wall motion, and ultimately the systolic dysfunction. Pathophysiology of myocardial infarction in short. আগেরটা অলরেডি ডিসকাস করা হয়েছে, এখানে নতুন করে যাচ্ছি না। ফর এক্সাম্পল, ডিগ্রি অফ lumen encroachment and status of the lumen, stable angina pectoris, unstable angina pectoris, and myocardial infarction is the STEMI. এক্ষেত্রে লক্ষ্য রাখো যে লুমিনাল এনক্রোচমেন্ট এবং লুমিনাল ন্যারোয়িং তার উপর ডিপেন্ড করে ক্লিনিক্যাল ম্যানিফেস্টেশনস বা ক্লিনিক্যাল কনসিকুয়েন্সেসগুলো আসতে শুরু করবে। In summary, coronary artery occlusion, reduced perfusion, ischemia and hypoxemia, cellular injury and necrosis progression, inflammatory response, and the healing process. Types of ischemic heart disease. Now, the current nomenclature, coronary syndromes, and the new nomenclature or future nomenclature is myocardial ischemic syndromes. Current nomenclature, acute and chronic. Acute means acute coronary syndrome. এটা পরবর্তীকালে আলোচ্য বিষয় হয়ে দাঁড়াবে। সেকেন্ড হচ্ছে ক্রনিক, chronic coronary syndromes, chronic coronary disease, as for example, chronic stable angina. New nomenclature, myocardial ischemic syndromes, acute, that is acute coronary syndromes caused by rupture or erosion, myocardial infarct with non-obstructive coronary arteries. This is the acute. Second is non-acute ischemia caused by epicardial coronary stenosis or ischemia with non-obstructive coronary pathology. So new nomenclature, myocardial ischemic syndrome, and current nomenclature is coronary syndrome, that is acute or chronic. Again, myocardial ischemic syndromes may be acute or chronic. Now, types of AMI. Myocardial infarction কে আমরা 5টা ক্যাটাগরিতে ভাগ করতে পারি। ক্যাটাগরি 1 or type 1, type 2, type 3, 4A and 4B. Type 1, that is spontaneous myocardial infarction with ischemia due to coronary event in the form of plaque erosion, rupture or thrombosis. Second, myocardial infarction secondary to ischemia due to the classical mismatch strategy like coronary spasm, coronary embolism, anemia, arrhythmia, hypertension as well as hypotension. Type 3, diagnosis of MI in sudden cardiac death. অনেক সময় দেখা যায় একটি স্টেবল পেশেন্ট, ইউজুয়ালি ইয়াঙ্গার এজ গ্রুপ, সব ঠিকঠাক আছে, সকালে উঠে দেখা গেছে মারা গেছে। দিস ইজ দ্য টাইপ 3. টাইপ 4A, AMI related to PCI, অর্থাৎ infarct related to the procedure of percutaneous coronary intervention. 4B related to stent thrombosis, and 5, that is AMI related to CABG, coronary artery bypass graft. Now, the clinical consequences. As a result of myocardial ischemia, the degree of ischemia, duration of ischemia, presence or absence of the collaterals, and the overall status of the collaterals, as well as other comorbidities and cofactors. Myocardial ischemia may present as chronic stable angina, that means an episodic clinical symptoms and signs as a result of myocardial ischemia that is transient in nature, usually with a duration of 2 to 5 minutes, occurs on exertion, crescendo, decrescendo in type, and much more common in male in the age group of less than 50, or in case of female in the age group of less than 60. This is the chronic stable angina. এটা থাক, এটা পরে বলা যাচ্ছে। Management of chronic stable angina. First, explanation of the problem and reassurance to the patient. Second, identification and treatment of the aggravating factors. Third, recommendation for adaptation of lifestyle activity. Fourth, treatment of risk factors. And fifth, drug therapy for angina. And lastly, coronary revascularization. Now, acute coronary syndrome. What is acute coronary syndrome? Coronary syndrome or acute coronary syndrome, that is ACS, encompass a wide spectrum of clinical presentation with a recent increase in the symptoms and signs. Second, a recent change in the electrocardiogram. Third, a change in the level of cardiac troponin concentration. So, acute coronary syndromes encompass a wide spectrum that includes clinical presentation with a recent increase in the symptoms and signs or a change in the electrocardiogram or a change in the level of cardiac troponin concentration. Now, acute coronary syndrome can be subcategorized unstable angina, non-ST segment elevation angina, and non-ST segment elevation AMI, and the ST segment elevation AMI or myocardial infarction. Now, recent changes in clinical symptoms or signs with or without changes on a 12-lead ECG and with or without acute elevation in cardiac troponin concentration. Acute coronary syndrome is categorized into acute AMI or unstable angina, and acute AMI is also again subdivided into ST segment elevation or non-ST segment elevation. Now, what is unstable angina? What is infarct? Acute elevation in the level of cardiac troponin concentration is a crucial or differentiating point between the unstable angina and the acute myocardial infarction, both ST-EMI or non-ST segment elevation AMI. Elevation of acute elevation of cardiac troponin level signifies myocardial injury. That means myocardial injury in the form of ischemic necrosis. So unstable angina is a result without the damage of the myocardium. That means without cardiomyocyte injury or necrosis. Again, I repeat, unstable angina pectoris is the result of myocardial ischemia but without cardiomyocyte injury or necrosis and without elevation of cardiac troponin concentration. The defining features are angina of long duration, usually angina at rest with a duration of 20 minutes or more. Second, new onset of severe angina. Third, angina that is increasing in frequency, severity, longer in duration, and lower in threshold. And lastly, post-infarct angina. Again, long angina at rest with a duration of 20 minutes or more. Second, new onset of severe angina. Third, angina that is increasing in frequency, severity, longer in duration, and lower in threshold. And lastly, angina that is the post myocardial infarct angina. Now, ACS spectrum. First of all, clinical presentation. Usually, acute coronary syndrome clinical presentation varies from symptom-free presentation to ongoing or persisting symptoms of ischemia such as chest pain, সেখান থেকে severe hemodynamic or electrical instability or even cardiogenic shock and cardiac arrest. So, the clinical manifestations of acute coronary syndrome is also a wide spectrum from no symptoms to cardiac arrest and death. In between, ongoing or persisting symptoms of chest pain, heart failure, cardiogenic shock, malignant arrhythmias, and sudden death. Now, spectrum. First, the clinical presentation, oligosymptomatic or asymptomatic. Second, symptoms of increasing chest pain. Third, symptoms of the persistent chest pain. Fourth, the cardiogenic shock or acute heart failure. And fifth, cardiac arrhythmias or electrical instability. Second, ECG findings. Normal, it may be depressed, it may be elevated, or reflection of the malignant arrhythmias. Now, the working diagnosis is non-ST segment elevation ACS. And when the ST segment elevated, then it is the ST segment elevated ACS. This is the working diagnosis. Again, clinical presentation, oligo or asymptomatic, symptoms of increasing chest pain, symptoms of persistent chest pain, cardiogenic shock and heart failure, and cardiac arrest. ECG findings, normal, ST segment depression, ST segment elevation, or evidence of the malignant arrhythmias. Working diagnosis, non-ST segment elevation ACS, ST segment elevation ACS. Then go for the estimation of cardiac troponin level. This will define as normal cardiac serum troponin concentration. So the diagnosis is unstable angina or non-ST segment elevation myocardial infarction. And when cardiac troponin concentration is high, the diagnosis is STEMI. So from the clinical presentation, ECG findings, then working diagnosis, then cardiac troponin concentration, then the final diagnosis. Now the passage to journey. Now this is the journey of ACS from the working diagnosis to a final diagnosis. First, clinical presentation, that is oligo or asymptomatic, There is increasing chest pain, persistent chest pain, cardiogenic shock, acute heart failure, or cardiac arrest. The immediate ECG within 10 minutes of FMC, that means first medical contact. সেক্ষেত্রে working diagnosis STEMI or non-STEMI আর precisely বলা ভালো non-ST segment elevation ACS, ST segment elevation ACS. Then go for additional studies depending on the clinical scenario, that is the cardiac troponin concentration, angiography, and the imaging. The ultimate or final diagnosis is STEMI, non-STEMI, unstable angina, and non-acute coronary syndrome. This is the trajectory or journey from the working diagnosis to a final diagnosis of acute coronary syndrome. On the basis of first ECG within 10 minutes of final first medical contact, then division into the non-ST segment or ST segment, then additional investigations depending on the clinical context, and lastly the final diagnosis in the form of STEMI, non-STEMI, unstable angina, and non-acute coronary syndrome. Clinical manifestations. ACS is associated with a broad range of clinical presentations. आगे बला होइछे symptom free presentation, ongoing chest pain, cardiac arrest, electrical, hemodynamic, and cardiogenic shock, or ultimately the other sorts of arrhythmias. A focused history on the points of risk factor for coronary arterial disease, then your clinical exam. First, history in the form of chest pain and elaboration of the chest pain, that is usually crushing, heaviness, squeezing, usually substernal or retrosternal, and with radiation in the left arm or right or both, especially the ulnar aspect of the forearm. And second, excessive diaphoresis, restlessness, and anxiety. Now, what would you expect in the exam from the 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. This is the exam protocol. 1 is the hand. Hand ki dekhte pari. Check for finger clubbing. Look for splinter hemorrhage. Identify infective endocarditis. And assess radial pulse. Evaluate radial pulse rhythm and note টেন্ডন জ্যান্থিমা। ফার্স্ট তারা দেখার চেষ্টা করছি nail bed, that is the capillary refill time related to the inadequate or low output state. কিভাবে দেখা হয়? Compress, release, and count. Normal duration usually less than 2 seconds. Then go for splinter hemorrhage. Then go for status like moist and cool. Then go for pulse. Usually pulse is variable. In a setting of inferior wall myocardial infarction, in the initial 1 hour or 2 hour, there is vagotonic activity producing bradycardia. In the setting of acute extensive myocardial infarction, again within the initial few hours, there is sympathetic overactivity producing tachycardia and hypertension. Or there may be arrhythmias from the premature ventricular contraction to both supraventricular and ventricular arrhythmia. Then go to the BP. Here we should look for hypotension or hypertension. Usually, myocardial infarction, when severe, produces a degree of hypotension by less than 15 millimeter of mercury from the pre-infarct stage. But in the setting of inferior wall infarct within the first 1 to 2 hours, or in the setting of anterior wall infarct within the 1 to 2 hours, then the first case there is the hypotension and bradycardia. The second case there is the sympathetic overactivity. There is hypertension. Then go to the jugular venous pulsation. Carotid pulsation. রেডিয়াল ব্রেকিয়াল হলো তো বলে দেওয়া হয়েছে carotid pulsation volume and character. Usually volume is reduced, character is unchanged unless or until complicated by the complications of acute myocardial infarction or the ischemic process. Jugular venous pulse. What would you search for the jugular venous pulse? Number 1, in a setting of right ventricular infarction, especially occurs in association with inferior wall or inferior posterior wall, there is jugular venous distension. In the setting of left ventricular infarct with the features of heart failure, there may be elevation of the jugular venous pulsation. Then the carotid, volume, character and bluey. Character may be a reflection of arrhythmias and bluey a reflection of the risk factor like atherosclerosis involving the carotids that may also involve the peripheral arteries as well as the coronary arteries. Now face diaphoresis or excessive sweating, central cyanosis, dental caries, fundi, that means retinopathy, reflection of the hypertensive disease, stigma of hyperlipidemia and thyroid disorders. Precordium. Precordium দেখার চেষ্টা কি করব। First, precordium is silently interquite. It is very difficult to palpate the apex beat. S1 is reduced in intensity. S2 shows paradoxical split. There may be mid-systolic or late systolic murmur as a result of mitral involvement of mitral valvular apparatus, especially papillary muscle dysfunction. Now this is the precordial findings. First, quiet, very difficult to palpate the apex beat. Second, S1 is diminished in intensity. Third, S2 shows paradoxical split. Fourth, presence of S4 or presence of S3. Then mid or late systolic murmur as a result of papillary dysfunction. And last but not the least, there may be a pericardial friction rub. This is the cardiac auscultatory findings in a setting of ischemic heart disease, especially acute myocardial infarction. Now the auscultation already opposite of the back, lung crepitations, reflection of heart failure, pulmonary edema, or cardiogenic shock, as well as the classification of heart failure on the basis of Keeley criteria, and abdomen, hepatomegaly, ascites, aortic aneurysm, and stool. Lastly, tendon xanthema as a reflection of the dyslipidemia. Diagnostic studies. রুটিন মেটাবলিক প্যানেল প্রত্যেকটার মতোই, অর্থাৎ কমপ্লিট হিমোগ্রাম, তারপর থাকছে থাইরয়েড ফাংশন টেস্ট, গ্লাইসেমিক স্ট্যাটাস, তার জন্য ফাস্টিং ব্লাড গ্লুকোজ and HbA1c, then lipid profile, GFR, troponin profile, 12-lead ECG, and imaging to detect the regional valve motion abnormality, certain cases, particularly uncertainty in the diagnosis of arrhythmias, Holter monitoring or ambulatory ECG, and X-ray chest. So routine, then the specific, and lastly the X-ray chest. This is the investigation profile. Now, exercise stress test, that is the treadmill test, that is very, very important in the chronic stable angina. Now, what is it? There is an increase in the incremental external workload, an increase or incremental increase in the external workload. An assessment of the ECG will constitute the basis of treadmill test or exercise stress test. This is the duration of exercise stress test is symptom limited. Distress in breathing, development of chest pain, development of arrhythmias, reduction of the systolic BP, extreme fatigability, we should terminate the exercise stress test. Now, defining criteria for ischemia, ST segment depression. দুটো জিনিসের কথা মাথায় রাখতে হবে, flat or down sloping ST segment depression from the J point with a duration of 0.08 second. So flat or down sloping ST segment at least 0.25 millivolt and with a duration of 0.08 seconds. This is the classical criterion for exercise stress test positivity. Initial assessment. এক্ষেত্রে প্রথমে আসছে ACS, ফার্স্ট হচ্ছে abnormal ECG, C for the clinical context and relevant investigations, and S mean stability, that may be clinical stability, hemodynamic stability, electrical stability. So ACS, abnormal ECG, C for clinical context, and S for the stability. Now, in short, management strategy. This is a strategy, not the detailed management. ACS presentation. Initial ACS assessment ECG, physical exam, clinical history, vital signs, and cardiac troponin concentration. Working diagnosis STEMI, non-STEMI, and non-ACS. First, STEMI, immediate angiography plus minus PPCI, percutaneous primary coronary intervention, ATT, anti-thrombotic therapy or fibrinolysis, যেখানে আমার PCI facilities নেই। Non-ST segment elevation, সেক্ষেত্রে initial management is PCI plus minus. The immediate angiography in case of very high risk factors, সেগুলো কি পড়ে আসছে, সেক্ষেত্রে ইমিডিয়েট অ্যাঞ্জিওগ্রাফি প্লাস পিসিআই। এই নন স্টেজ সেগমেন্ট এলিভেশনে কিন্তু ফিব্রিনোলাইসিসের কোনো রোল নেই, এক্ষেত্রে সরাসরি পিসিআই অ্যান্ড অ্যান্টি থ্রম্বোটিক থেরাপি। আর নন স্টেজ সেগমেন্ট ACS, সেক্ষেত্রেও আমাদেরকে দেখে নিতে হবে যদি হাই রিস্ক ফ্যাক্টর থাকে, সেখানে আর্লি ইনভেসিভ স্ট্র্যাটেজি, ভেরি হাই ইমিডিয়েট ইনভেসিভ স্ট্র্যাটেজি, দ্যাট ইজ সঙ্গে সঙ্গেই করতে হবে। আর যদি হাই রিস্ক থাকে তাহলে আর্লি, দ্যাট মিনস উইদিন 24 hours, দেন ক্যাটেগরি কি পিসিআই অ্যান্ড অ্যান্টি থ্রম্বোটিক থেরাপি। ক্লাসিক্যালি লক্ষ্য করে দেখো প্রত্যেকটাতেই কিন্তু অ্যান্টি থ্রম্বোটিক থেরাপি থাকছে, প্রত্যেকটাতেই কিন্তু পিসিআই থাকছে, শুধু ডিপেন্ড করছে STEMI, নন STEMI অ্যান্ড নন ACS। এক্ষেত্রে তফাৎ হচ্ছে যে আর্লি ইনভেসিভ স্ট্র্যাটেজি or immediate invasive strategy or early invasive strategy. Further management depending, যেখানে নন ইমিডিয়েট অ্যাঞ্জিওগ্রাফি করার সম্ভব হচ্ছে না, সেখানে আর্লি অর লেট অর প্রিডিটারমিন্ড অ্যাঞ্জিওগ্রাফি করে পিসিআই করা যেতে পারে অথবা সিএবিজি করা যেতে পারে। আদারওয়াইজ নন ইমিডিয়েট অ্যাঞ্জিওগ্রাফি না, সেক্ষেত্রে ইকোকার্ডিওগ্রাফি করে ডিসিশন নেওয়া যেতে পারে রিগার্ডিং পিসিআই অর সিএবিজি। আদার ইনভেস্টিগেটিভ প্রসিডিউরস ইন দ্য সেটিং অফ দ্য ইমিডিয়েট অ্যাঞ্জিওগ্রাফি, যেখানে সম্ভব হচ্ছে না, ইন্ট্রাভাস্কুলার ইমেজিং, নন ইনভেসিভ ইমেজিং, সেক্ষেত্রে লং টার্ম মেডিকেল থেরাপি। আর যেক্ষেত্রে হাই রিস্ক ফ্যাক্টর নট ভেরি হাই, সেক্ষেত্রে কার্ডিয়াক ট্রোপোনিন and ECG monitoring and long-term management মধ্যে lifestyle measures and the smoking cessation. Now the very high risk factors and high risk factors, এগুলো কি? A non-ST segment elevation ACS অথবা non-ST segment elevation MI, এর ক্ষেত্রে কিন্তু আমাদের একটা ডায়াগনস্টিক ডিলেমা থাকে, কারণ এসটি সেগমেন্ট আমাদের কিছু পজিটিভ ইনফরমেশন প্রোভাইড করে না, সেখানে রুল ইন রুল আউট অ্যান্ড অবজার্ভ পলিসিটাকে মেনটেন করতে হয়। হোয়াট ইজ রুল ইন রুল আউট? কারণ কার্ডিয়াক ট্রোপোনিন লেভেল ইউজুয়ালি অ্যাপিয়ার করা শুরু করে অ্যাট দ্য অনসেট অফ নেক্রোসিস, পিক হয় 12 to 24 hours, then declines gradually, usually elevated 7 to 14 days. Now, what is rule in, rule out? Strong suspicion of ST segment elevation without an immediate indication for angiography. Go for estimation of cardiac troponin level at 0 hour, at 1 hour at 2 hour. তিনটে রেজাল্ট আসতে পারে। ফার্স্ট রেজাল্ট ইনিশিয়াল ভেরি লো and no increase in cardiac troponin level at 1 hour or 2 hour. সেক্ষেত্রে রুল আউট পলিসি, অর্থাৎ অন্য কিছু ভাববার দরকার নেই। অন্য ক্ষেত্রে যেখানে হাই ইনিশিয়াল অথবা ইনক্রিজ ইন কার্ডিয়াক ট্রোপোনিন at 1 hour or 2 hour, then it should be included in the emergency therapeutic strategy or triage. And this is the rule in phenomenon or rule in strategy. In between these two, observation is the best policy. This is the rule in, rule out, and the observation strategy on the basis of serial estimation of cardiac troponin concentration at 0 hour, at 1 hour, at 2 hour. This is the summary and pictorial representation of my approach. Risk factor for stable angina. Stable angina. This is the STEMI score. কতগুলো স্কোর আছে? টিমি স্কোর আছে, গ্রেস স্কোর আছে, হার্ট স্কোর আছে। হার্টটা মনে রাখা সহজ। টিমি স্কোর হচ্ছে যে থ্রম্বোলাইসিস ইন মায়োকার্ডিয়াল ইনফার্কশন ট্রায়াল। সেখানে 7টি ফ্যাক্টর আছে। 1, এজ মোর দেন 65 years, মোর দেন 3 coronary artery disease. Risk factors like hypertension, hyperlipidemia, family history, diabetes, smoking. 3 or more. Non-CAD, that means stenosis equal to or exceeding 50%. Then aspirin used in the last 7 days. Severe angina, more than 2 episodes in the previous 24 hours. Then ST segment deviation on the ECG by more than 1 millimeter. And the total score 0 to 1, risk আলাদা 2 to 3, এগুলো বলার চেষ্টা করছি না। হিস্ট্রিটা কি বলা হয়ে গেছে? Now, ST segment elevation acute coronary syndrome. What is it? দুটো জিনিসের কথা ব্যাখ্যা করবো। একটা হচ্ছে ST segment elevation ACS আর ST segment elevation MI. ST segment elevation ACS means ST segment elevation increasing or persistent chest pain consistent with myocardial ischemia with elevation of the ST segment or elevation of ST segment equivalence, known as ST segment elevation ACS. কি সেক্ষেত্রে বললাম ST segment elevation or ST segment elevation equivalence, এটা পরে ব্যাখ্যা করব। আর নন ST segment elevation ACS, সেক্ষেত্রে ব্যাপারটা ঘটছে যে ST segment deviation থাকতে পারে, not elevation, in the form of either Wallen's sign or Winter syndrome, etc., etc. Now, ST segment elevation myocardial infarction. অর্থাৎ এটা ST segment elevation MI. ST segment elevation more than or equal to 2.5 millimeter at the J point in 2 contiguous leads in a male subject aged less than 40 years. আর এজ যদি দেখা যায় 40 ইয়ার্সের বেশি, সেক্ষেত্রে হচ্ছে 2 millimeter or more, or in case of female, surprisingly 1.5 millimeter or more, and or 1 millimeter or more in other leads in the absence of left ventricular hypertrophy or left bundle branch block. Left ventricular hypertrophy এবং left bundle branch ব্লকের ক্ষেত্রে আমরা এসটি সেগমেন্ট এলিভেশন ইকুইভ্যালেন্স, আজকে বলার টাইম নেই, এসটি সেগমেন্ট এলিভেশন ইকুইভ্যালেন্সের কথা ভাববো। রিপিট করছি, এসটি সেগমেন্ট এলিভেশন এর যে পয়েন্ট by 2.5 or more in male subject with age less than 40 years, or 2 or more in a male subject age 40 years or more, or 1.5 millimeter or more in case of female, and or 1 millimeter or more in other leads.